So even to say, MBBS is not sufficient. I mean, a lot of people in India would challenge that notion. I mean, traditionally, we all have this idea that once you have done your MBBS, your knowledge is sufficient enough. Like we assume in India that because the examination is so competitive to get into MBBS, and MBBS is also such a rigorous course, and you do study all subjects and do your rotation internship. Why it is not sufficient? I mean, to practice as a family physician, as a family doctor. Why extra training is required? Why would one based? I mean, they say that is an extended rotation internship, or like why do you want to do more of the same MBBS course is already done? How does this extra training or education add to the value of a MBBS doctor?
Dr. Kumar, it's the complexity of medicine. Okay, medicine, as you know, is a very complex field. General practitioners are experts at navigating the multiple comorbidities that can affect a person. Okay, and for that you need extra training. An MBBS graduate goes through different specialities, but they don't really understand the navigation of a complicated healthcare model. Now look at a general practitioner's role or a family physician's role. They will be able to interpret different disease patterns. They will work as a common factor where the patient feeds in, the specialist feeds in, the allied health feeds in. All that information comes through to one person. That person that sits makes sense of this information and then gives you an answer. Okay? If that is not an expert in their field, then who is? Okay? So you are trying to treat a human body with all its different bones, its blood vessels, its, all the different systems, and you're one person. So just a 5.5-year MBBS course is not going to give you that information or that expertise to deal with so many multifaceted things.
Experience.
100%.
Seen, how many patients.
100%.
We've seen how many complexities.
Absolutely.
Face to face.
Absolutely.
So, in internship, you're sent to one department for 15 days, 30 days, 1 month, 2 months, and that experience is not sufficient enough to become expert in that domain.
That's correct. And when you go through general practice training, and I can talk about the Western environment because that's where I've been trained, besides the hospital part of the training, which essentially you do it through your MBBS as well, but you do a slightly more protracted term of it, the experience that I found was most enriching was actually in the general practice settings, because you get to see real patients. You get to make sense of all the health information. You are being taught how to deal with complex problems. You deal with things like breaking bad news, palliative care. You don't get to see palliative care as a medical student. A huge part of your work as a GP would be to actually provide palliative care to people who are dying. So it's only general practice training that prepares you for that.
That we advocate family medicine in India. One of the criticism we receive that this is a Western concept. Like it was good for maybe UK, Australia, New Zealand. But India does not need this kind of system. Our system is good enough. And we are doing good. I mean, we make good doctors. We make doctors for UK. Yes. So why do we need to incorporate this foreign concept to the Indian system? I mean, because you have seen both sides. Do you have any answers?
Yes, I do. It is never a foreign system. It was never meant to be a foreign system. The only reason it's a foreign system is because we failed to implement it in time in India.
Right.
Okay. In a country where we have the highest population in the world, where every person has healthcare needs of a different kind, where we have got tier 2 and tier 3 cities where affordability to go and see a specialist is very minuscule, we need general practitioners more than ever, because we need them to be able to treat people at a community healthcare level so that they don't flood the public health system, number one, and we get better outcomes for every person in India, which is a huge task. You're talking about, UK and Australia. The population of Australia is less than northeast of India. We are talking about like 7 Australias in India here. Okay. So if Australia can implement a healthcare system that improves their health outcomes, we need to exit by another 10 times to make it applicable to a country as big as India.
So you mean to say that the value of family physicians, family medicine, family doctors is more for India as compared to
100%. 100%. And also because the self-awareness for health is higher in a developed country. And we all know that, but the self-awareness to be that level of self-awareness to start in India, we need the general practitioners to be active. We need them in the communities. We need them in primary healthcare centers so that that awareness can start. Unless a person can become self-aware of their own needs, it is impossible for you to treat a person.
So, we're talking about the training requirements of family physicians. We call family medicine specialty in India. Would you describe a typical model of family medicine training program, the training center? How do the trainers or faculty or universities are involved in this training program? How does the licensing system of the training programs works in Australia also?
I can talk about Australia for the moment because I've been actively involved with it. So the training program right now is dealt with by the Royal College of General Practice. So a medical graduate would do their, most universities in Australia, medicine is a postgraduate degree. It's not an undergraduate degree. So they would have done their undergraduate medicine, then come into undergraduate degree, then come into postgraduate medicine degree, at the end of which they would have their equivalent of an MBBS. Then they would go through a year of internship. Now it's 2 years. At the end of 2 years, then they would apply to go and join a training program with the Royal College of General Practice. And once they apply for the training program and they're accepted, and mind you, the acceptance rate is also low and it's very competitive, then they would go through a period of supervised hospital training.
So we're talking about the training programs in Australia, family medicine. We would enroll with or engage with Royal Australian College of General Practice. And how does a typical training program last? Like, what is the duration? Where does the training take place? What is the postings, departments or hospitals or GP clinics? What called? How does it work?
So basically, the training program is a 3-year program. The initial 12 months they would spend within the hospital system, and they would rotate through different specialties that are relevant to general practice, like obs and gynae, pediatrics, general medicine, emergency medicine, and then the rest of the time, another 18 months is spent in a supervised general practice setting, where you have a designated supervisor who would supervise your training, at the end of which you would apply for the Royal College exams to gain your fellowship. And only when you gain your fellowship, then you are eligible to apply for registration with AFRA, which is the licensing body for Australia. And once you get licensing, then you practice as a specialist in family medicine.
Okay. So, why is hospital trainings involved? And what is the importance of the training at a GP clinic? I mean, there are 2 different domains of training.
Yes.
During 3 years. What is the logic to both aspects? Hospital training, GP clinic.
Remember, Dr. Kumar, the number of cases that you see in the hospital from the community is a minuscule of what general practice settings will see. Okay. General practice is a specialty where you can choose to do as much or as little as you choose. You can be a GP and a GP alone, and that is a really important job, and a family physician. But in places like Australia and the UK, you can subspecialize as well, more so in Australia. And you can choose to, like, I do general practice. I run primary health care, sleep apnea clinics. I also do skin cancer. I have got advanced certificates in skin cancer medicine and surgery. So if someone comes to see me with skin cancer, and Australia has one of the highest rates of skin cancer in the world, they would have their skin cancer treated at a primary care level. They do not need to go and see a dermatologist or a plastic surgeon to have that skin cancer treated. So to be able to provide that sort of a service in the community, I need a period of training in the hospital where I can train under different specialties. So I can bring that information to the community and I can stop those patients from going into the hospital.
So GPs prevent hospitalizations or prevent patients from going to the specialist. Does it create any professional conflict among professionals, specialists or GPs?
Not really. I think the hallmark of a good healthcare system is a complementary and symbiotic relationship between a general practitioner and a specialist. A specialist wants to see cases that are pertinent to their specialty. If there is the lack of a good gatekeeper, that particular specialist is going to be overwhelmed with the amount of patients who, for want of a better word, self-diagnose themselves and reach that specialist door. So, and the specialist, on the other hand, would expect that that patient would have a good general practitioner who stops them at a community level so that the cases that filter across to a specialist are the cases the specialist needs to see or wants to see, because their time is best invested in that.
So specialists would want to see more of what they are trained for.
100%.
But more of what they are supposed to do.
100%.
Than doing,
100%.
things that are supposed to look.
And Dr. Kumar, in a country like India, it's even more important. With more than 1.2 billion people, I was reading an article the other day which said that for 10,000 people, we have one doctor. Okay? So if all those 10,000 were to appear at your door, I don't think you'd be very happy. You'd probably want someone to filter those amount of people.
So you are doing professional leadership in Australia.
Yes.
We have today a few hundreds doctors come in Delhi of Indian origin. And what is your message to the government policy makers or Minister of Health for future of India's health?
I believe that the core value behind any healthcare system is a functioning and strong primary healthcare network. And I'm using the word network because it is a network of people. It is a network of general practitioners. It's a network of allied health professionals. It's a network of pharmacists. It's a network of nurses who work as a team. And that team needs to be led by someone, and that's the family physician. So my message, and I'm perhaps no one to say this. I mean, there's stalwarts like yourself in the system. But my message would be, make your GP strong. Make your generalist strong. You make your generalist strong, you'll make your healthcare system strong. In a country where health outcomes are not the best in the world, but a country that's coming of age, where development is happening at such a furious rate, I think we need to invest that time, finance, and effort into financing a robust primary healthcare system so that the secondary healthcare system can actually see the patients that they're meant to see, and overall health outcomes and especially prevention improves.
So great. It was great talking to you, Dr. Sharma, and thank you for sparing your time for us. And I hope that this conversation, when it is disseminated, will be useful for public policy makers, ourselves, students, professionals.